Absolute pleasure of being joined today by Jane Rooney. Jane Rooney's a specialist sports physiotherapist and an ACL expert in Melbourne. And Jane, welcome to today's chat.
Thanks, Mick. Always enjoy chatting with you, just two fellow knee nerds. Hey.
I know it is. We are. We've got together a few times over the years, and it's always lovely to talk shop. I've got like utmost respect for your work and the work you're doing, and I've certainly modelled a lot of my practice off you and the standards you set. So it's great to sort of talk shop again today. And today we're going to talk a little bit about cross bracing protocol and a bit of ACL healing. But for those that haven't come across you before, Jane, which will probably be very few people, I've got some people that come in from America and the UK and join the ACL Hub. But can you just tell us a little bit about your background and your history, just so we can bring people up to speed?
So I suppose I've been really interested in ACLs for about the last 20 years. And I did my specialisation back in 2009 where I subspecialised in the knee. So really from 2009, my clinical practice has just been seeing knees all day, every day. And I still love it. So that's great because there's so many different knees. And this project that I'm involved with now has injected just another level of energy into what I'm doing. And I suppose I feel very humbled to be able to try to leave some sort of legacy in my time, in my career, to change things for the better for people with ACL injuries, which unfortunately there's more and more of them because the incidence rate is rising. So then after I did my specialisation, I was awarded a Churchill Fellowship in 2016, travelling for 3 months in 2018, just got that in before COVID, which was lucky. And I was particularly looking at, so I'm very grateful to the Churchill Trust for that, who funded my travels. And for 3 months around a whole lot of different countries, so the UK, Ireland, Netherlands, Denmark, Norway, Sweden, and the States, looking at ACL injury management algorithms, prehab programs, non-op programs, post-op programs, and long-term management programs, so like the GLAD program, etc. in Denmark. And Sweden I also went to as well. And so I came back and wrote a report, which you can actually get for free on the Churchill website, and with some recommendations and summaries. And it's quite interesting when I look back, because I obviously wrote that quite a long time ago now, 2018. But a lot of those things are still really relevant. And I'm pleased that I'm ticking some of those recommendations off myself. So when I came back, I then started to collaborate with Dr. Stephanie Filbay, who I met on my studies, to set up a shared decision-making research project, because I suppose in a nutshell, what I learned is that the algorithm of ACL injury management varied from country to country. Even I'm pretty sure our ACLs are the same, whether you're Swedish, Australian, American, etc. But what is different is the health system, and the funding of that injury is different in different countries. And so we set about making some surveys about shared decision-making in ACL injury management as in the Australian population. And that was really interesting, and we can talk a little bit about that. That culminated in the online publication of the free patient decision aid on www.aclinjurytreatment.com, which helps people look at non-operative versus operative and all the pros and cons of each option, really just including the peer-reviewed, published research, so in a non or as little bias as possible, because of course when you go onto the internet there's a whole lot of information for people out there, and some of it is not credible, obviously. Well, that's in a nutshell. And I suppose then from then I met Dr. Tom Cross when I was presenting some of this work at the Australian Sports Physician Conference just before COVID in 2020. And he was very, in the early days, although he did start in 2014, but I think I braced number 4 in 2020. So it was quite early on in the research as far as numbers go. And So I was involved from very early days because we identified that we had similar, well, we were involved in projects that would dovetail nicely with each other. So I've been involved in the cross bracing for the last 5 years. So.
Yeah, massive undertaking, and that would have been a fascinating trip around the world, looking at the different systems, and I think that's where you got such a great and unique perspective on how things are currently being done, and probably have been done over the last 10, 20 years, and kind of can hopefully get the crystal ball out and start seeing how things may look in the next 5, 10, 15 years ahead. Those that may not have heard about the cross bracing protocol, which once again probably few people these days, it's certainly gaining a lot of traction and a bit of interest. Can you kind of take us back to, I guess, the foundation about Tom's original work and Tom's kind of original thinking about what the cross bracing protocol could do to the ACL injured knee, and also to maybe talk about some of those early findings that you found in that first paper.
So I suppose the interesting thing is it was really probably instigated by a patient who, funnily enough, I actually met last year because she re-injured her ACL 10 years later. So she did the bracing protocol for the second time and got a heel the second time, a very good quality heel. So there you go. That's a funny whole circle. I was like, wow, I feel like I'm meeting royalty, like patient zero of the cross bracing
patient zero. Yes.
So patient zero was a young 19-year-old girl who didn't want surgery. I think she had some experience with other people who had had surgery that hadn't had a good experience with it. And she wanted to try anything else. And she was consulting Tom at the time. And Tom tells the story that his father was in the clinic, who is a very eminent orthopedic surgeon. One of the first, who did arthroscopes, knee arthroscopes in Australia, was a very eminent ACL surgeon. And he said, well, Tom, back in the day, we used to plaster knees at 90 degrees, and some of them used to do okay, and we've got no idea why. And in fact, interestingly enough, when I first moved to Melbourne back in 1996, there were still a few surgeons. I looked after a few of these knees that were plastered at 90 degrees. So I've been around long enough to actually know this old treatment. But of course, MRI wasn't very accessible back then. So, as Merv said, this is Merv Cross, who's the orthopedic surgeon, Tom's father, said, well, we don't really know what happened, but some of them used to do okay. But of course, we also remember some of them used to get very stiff, very bad patellofemoral sort of problems afterwards, a lot of muscle wasting and skin problems because, you're in a plaster for a long time. So Tom then said, well, nowadays we've actually got braces that are as restrictive, if you like, as plasters, but you have more access to the skin. You can take them off, leave the knee at 90 degrees. And I suppose 90 degrees was chosen as a compromise between the safety of the neurovascular bundle at the back of the popliteal fossa, not being compressed, because of course both bundles, the ACL posterior lateral and the anterior medial bundle, are shortest at 135, but they're still very short at 90 and longer in extension. So as I say, it's a little bit like, imagine if you were bracing an MCL and you braced it in valgus and then you were surprised that it healed long and it didn't really do its job, right? That would be crazy, right? So a bit like if you braced an ACL in an extension Zimmer splint, it's what often happens still in emergency departments. So 90 degrees was chosen as a position to put the ruptured ends of the ACL in close approximation to each other. Hope that, I suppose, healing would be more possible. Do you know? And then when healing did occur, it would heal in close to its anatomical length as possible. I suppose that in a nutshell.
Yeah, no, excellent. And what in that initial 80 patients, there was a paper published. What were the original findings for those that
are the original findings of that were that we had a 90% heal rate. So I was one of the co-authors of that paper with Dr. Stephanie Filbay and Tom, and there was a whole number of other physios from the Stadium Clinic who set up the original rehab protocols. And basically there was a 90% heal rate, But the healing, so we talk about an ACL-OS score, and a 0 is a normal ligament. An ACL-OS of 1 is a normal looking ligament, but it's not as mature as a 0. And then a 2 is either a thinner or longer, or thinner and longer, ligament, and a 3 is a non-heel or a non-anatomical heel. So it might join to the PCL or the lateral wall.
Yeah.
So in that 90% of people that healed, 50% of people healed with a grade 1 heel. So that is the best quality heel. This is at 12 weeks. 40% healed with a grade 2 heel. So this is the either thinner, longer, or thinner and longer. And then 10% didn't heal. But of those, actually, most of them either attached to the PCL or the lateral wall of the condylar notch. So we don't really know what that construct is, although I've looked at many of them, and some people it seems to be enough dynamic control, because as we know, there's always copers who I absolutely know are ACL deficient anyway. So this further complicates the copers, non-copers, which we can talk a little bit about later. But so that was our findings. And I suppose the other important finding to mention at this point is that in the first 11, there were 2 people that sustained DVTs. And that was before the anticoagulation schedule. So I suppose this is like a note of safety that you should never put your knee in a brace at 90 degrees unless you are under the care of a medical doctor with anticoagulation. And certainly I've been in a lot of the RCT meetings now, setting up the whole RCT that we're comparing ACLR with cross-bracing. And I've heard all the expert opinions of vascular physicians, hematologists, and all of those people. And they've got a very sort of defined anticoagulation schedule. So that's this is not something a physio can do by themselves. It needs to be done by with a medical professional.
And that's really important, because we just talked off air before that I've had at least one case that I can recall, and I know there's been some other experienced physios who've had patients turn up braced after 2 weeks, and it's like, have you seen a doctor? Have you had any kind of medical intervention to this point or consultation? And they're like, no, and it's like, okay, well, let's take a breath, let's take a step back, because it inevitably will happen. It probably has happened many times already, and unfortunately, probably will happen again in the future. But this is what a big part of this conversation is to highlight the need for a team. And I think you've talked about this before. What would a team ideally look like? A physio medical team. What would that kind of look like if someone's going to wander down this path?
So I suppose if we talk about it from the very beginning, and I think about, like I've already had 4 calls this morning from people calling me to say, can you please help facilitate this patient to see if they're appropriate, etc.
Just a standard Monday for you?
Is that, so the first thing is that you do need a good 3T MRI. Okay, to actually define, well, first of all, you need to ascertain, has the person had an ACL injury, number one, and is it an index injury, or is it actually an instability episode of an index injury that happened a number of months ago? Now, we've seen a number of these as well, okay? So that's the first thing. So and that will vary from country to country, because obviously in Australia, we are primary contact practitioners as physios. So sometimes they might present to us after the weekend. And part of it is getting a good subjective history, like what happened, what sort of injury was it? Did you feel any, pop, or did you hear any noises at the time? Did you get a hemarthrosis, like the big, swelling? Although sometimes we see that people don't present with that, because I've seen so many acute ACLs now. I probably see 5 a day in my clinical practice acutely now. So I see lots in a week. So I'm seeing such the spectrum of how people present, even acutely. So from that point, they need an MRI. Now, from country to country, and even within our country, so regional and rural access to MRI is not as good as in the city. Do you know, like, so,
Yeah.
and then even in the city, we like people to have, and again, this is the work of Dr. Tom Cross and Rowan Sharble, his radiologist that he works closely with, is that you need a double oblique sequence, which gives you the gun barrel view of the ACL and how it actually inserts into the femoral footprint, right? Because we want to see if that is actually disrupted or not. So you need a 1T MRI doesn't give us enough definition of the whole injury. So we often need, and we need another MRI if that's the case. So you need a recent MRI. It needs to be of a good quality, and ideally it needs to have a double oblique sequence. Okay, so that's the first thing. You need to know what
is that not standard, Jane? For
not standard, no. So in Melbourne, there's 2 clinics that definitely do it, which is IMED in South Yarra, where I work above, and then Olympic Park. I know in Adelaide, there's I think Jones and Partners are doing it, and then because I've just taught a course on the weekend where people have come from all sorts of different parts of the country, and I believe in the Gold Coast and in Queensland, there's a few centres as well. So I think there are getting more centres that are doing this.
Yep.
And I suppose it's just important when we talk about the shared decision making, because that's part of it, is to try to be able to give people a prediction of what their possible heal is going to be like, sort of related to their MRI, which we'll talk a little bit about. So the team so far is that you need a good MRI, right?
Yes.
And ideally, you would have a radiologist who knows actually a little bit more about, rather than just writing ACL rupture, they might say, complete rupture, gap distance between the bundles, 6 millimeters, no displacement or, minimal displacement, femoral footprint, trauma, or no evidence of femoral footprint trauma, right? And then from then you really need to, and obviously before that in Australia, you need to have a GP that refers you for that, or a sports physician, because if you want to get it bulk billed by Medicare, physios don't have that scope. But in other countries, I know it is more difficult, and there's more limited access and different triage pathways. So then from then, the patient, so I work remotely closely with Dr. Tom Cross. So he is involved in nearly every patient I'm involved with, or there's a few other sports physicians in Melbourne that are now being interested in this. And he will take a thorough medical history and work out if they have either an increased risk of clotting, or they have a possible risk from they can't take anticoagulants for any particular reason. In a nutshell, I suppose that's the medical screening of that risk. But there are other things that we need to screen medically as well. Do they have rheumatoid arthritis, diabetes? Do they have lots of other things that they screen? And so you need a GP or a sports physician to be able to screen that. And of course, Tom is very knowledgeable. I mean, he's the all-being, all-knowing sort of person in this protocol. And he talks to people about, from the data, from your MRI, this is the predicted healing that I predict that you've got a 75% chance of getting a meaningful heal, or a 50% chance, or a 90% chance, etc., which enables people to think, do I want to take the time and the inconvenience risk for a 50% chance or not? And that we can talk about that, because it sort of depends on your demand, right? And then you need somebody that can provide you with a brace. Now, in Melbourne, in my clinic, I have the whole range, like from the cheaper ROM braces, which are adequate, and the first 80 did have those, like the Ossa or the Don Joy ROM, all the way through to the Bauerfeind Secutech or the MediComfort 4, which are the more hard shell restricted braces. I mean, saying that, I had somebody on telehealth that sort of just had a brace that was, I don't know what type of brace, and he got some cable ties from a hardware shop and locked them at different ranges, right? So, I mean, I suppose
so good.
In a third world country, you could get 4 sticks and lash them at different, so you need a brace of some description that provides you with enough stability and control to change the angles as required. And there are pros and cons of the different braces and different price points as well. And then, of course, you need a physio who manages you through that whole journey, and sees you basically weekly while you're in the bracing protocol to not only take the brace off, do some manual therapy, massage, mobilization of the patellofemoral joint, superior hip joint, and manage your exercises, make sure that you're doing your calf pumps for circulation, check for any pressure areas, and then progress your rehab as the brace angle changes. So, that's the team, I suppose. And then ideally, we like to have a surgeon as well that can work collaboratively with us, so that for some people, I've had people that have had a meniscal lesion, a tear at the time, and they've still opted for the protocol. And in our case series, 38 of those 39 with meniscal tears did actually heal or became asymptomatic. But certainly I've probably done enough volume now that I've had a few that haven't and have had to go for delayed meniscal repair. So it's really nice. And in fact, one patient I've had recently, which was really interesting, the surgeon is very open-minded, and she's done a meniscal repair with an augmentation of her heel. So she had a beautiful heel, but it was a grade 2 heel. So it was a little bit thinner in the healing zone and a little bit looser. And so she took just the gracilis and did the gracilis next to her heel. So, and I mean, look, she's only about 6 weeks post-op, so we'll see how she goes. But that's a really interesting sort of process, because she said, well, I don't want to cut this beautiful healed ACL out because it's got a nice blood supply. It's probably, who knows what happens to the proprioceptive fibers if they are better in a heel than a graft. We don't really know. But she said, I don't want to cut this out because it's a construct that's joining the femur to the tibia.
It's doing a job.
And it's in its anatomical footprint on either end. So,
that's it's like that is just such a fascinating insight, because I think there's a lot of people, a lot of even young physios, health professionals who kind of just imagine they're the kind of central figure, but this is a true multidisciplinary team that needs to be involved in the patient's care. So to do it on your own, I think is one, it's not the right thing, to do.
Yeah, absolutely. I absolutely agree. We don't want the lone rangers out there doing it by themselves. I mean, you could kill somebody, right, if they got a DVT and a PE. And in fact, we've got the other things that are really important to mention is certainly, and in the RCT, this is the rule based on, the expert evidence that we have been advised of, is that if anybody's ruptured their ACL and then flown anywhere afterwards, that scores them. They have to have a Doppler ultrasound before they go into the case to check. So last year, to check they don't have a DVT. Last year, I probably picked up 25 DVTs.
Wow.
People that they're not in the brace, they're coming to be assessed if the brace is appropriate. And most of them are skiing in Aspen or Japan or something, and then flying back and not being anticoagulated on the flight. The thing is, if they've if they've injured their knee in the snow and then had a continuous car journey for more than 2 hours, they also have to have a Doppler ultrasound. As well as anybody that has any signs of a DVT, which could be a hot red calf or a visible cord, or that they can't dorsiflex their foot comfortably with walking, or they have a really painful calf on squeezing it or palpating it. And there are occult DVTs that occur as well. So this is certainly one of the risks that need to be carefully managed.
It's absolutely worst case scenario for a physio. There's probably not too many situations where we potentially do impact people's lives, but missed DVT is certainly one of those ones that are so important that you just don't want to play around with and cannot miss. What were some of the early lessons learned from that first 80? I think sort of, like you've talked about, obviously the DVT and the anticoagulants coming on board after the first 11.
Yeah.
Is there any healing factors that also too came through and shone through as to who's appropriate?
Yeah, and I suppose like most of the first 80, because like this is like, we also have to talk a little bit about the history of when this happened, because this happened in COVID times, in Melbourne and in Sydney, right? So and for people around the rest of the world listening, I mean, I know we all had our own experiences of COVID and they were all very unique, only different from one country and even one city and state to another. But certainly in Sydney and Melbourne, well, Melbourne, we had some of the strongest lockdowns and longest lockdowns around the world. And certainly surgery was discontinued for quite a long period of time. And Sydney was similar, but not quite as extreme. So, but basically a lot of this was happening in that time, so where people came back from skiing holidays, they'd ruptured their ACL, there was no access to surgery. So it was sort of probably fortuitous in some way as far as the research goes to get these people, because bracing was possible in that time.
Yes. Yeah.
But yeah, so a lot of these lessons were learnt by Tom and the stadium clinic staff at that time, because they did the majority of those first 80, is that, there were things like for the people that were non-weight bearing, when they did start weight bearing, they often got some bony stress reloading pain. So, and we've seen that, across other sort of non-weight bearing sort of protocols. And so now, I suppose, as soon as they are possibly able to weight bear, which is really when they go 90 to 60, I'm quite strict about getting them to do weight bearing through the ball of their foot. Do you know, like, so to get, and they're allowed to weight bear for all the exercises as well at 90 degrees. So certainly bony stress reloading. The other thing was, I suppose, retrospectively looking back, because a lot of this was not known at the time. And this was really Tom and his radiologist and Steph looking back at the data and looking at like what were the factors that tended to lead to a grade 2 heal versus a grade 1 heal, and also time. So we had people up to day 28 in the first 80. But certainly when we look back at all the stats, once you get to day 16, the day 16 post-injury, the rate of healing tends to drop off, which is why the day 16 is in the RCT, that you have to be in the first 16 days. So it is a time-sensitive protocol. And I explain to patients a little bit like, if you cut yourself and you let it open for a week or two, and then you go, I might put some steri strips on it now, it's probably not going to be the best heal, right? Then if you put the steri strips on immediately, so the body heals, but it's a time. And it's the same with broken bones, if you don't plaster them in the right time zone, all of those things. So time is a factor. The other thing that tends to be a factor is if you have any trauma and how much trauma to the femoral footprint. So the majority of people, so I think it was only 18% of people that had a grade 1 heal had trauma to their femoral footprint, whereas 93% of people or something like that that had a grade 2 heal had trauma to their femoral footprint. So that's another part of the inclusion criteria to the RCT, is that if you have more than 20 or 25%, interrogation of the femoral footprint, then that is a poorer predictor of healing. And then also displacement, because can you imagine, like, if you have like the ACL and then it ruptures like this, obviously the further these structures are apart from each other, the harder, it is for the little collagen fibrils to grow together. So certainly we've got a distance now of 8 millimeters, which is if you have more than 8 millimeters apart, then the healing potential is also less. And the displacement. So the displacement's almost like if you just pull it apart like this is a non-displaced ACL. But suddenly part of it flips forward to the intercondylar notch. Sometimes it seems to flip back and heal with its body up here.
Yep.
And other times the body just, the body scavenger cells eat up this.
Yep, just eat it up.
And then you get a thinner part of the heel here.
Yep.
So, and those reduced volumes, we can talk about different, heels and different qualities of heels and risks and things like that. But yeah, so that's so it's about days post-injury, it's about MRI factors, it's about bone reloading, it's about the anticoagulation as well. As well as probably some of the difficulties that people encountered just personally, like trying to walk on, like all those. So how can we help their mobility? How do we help them? What resources can we help them to make their journey in this protocol a little bit easier? All of those.
Yeah. Well, that's just, it sort of sings to the importance of making sure that you've got a good team around you, because those factors in particular, even if we just look at the femoral attachment, interrogation and the distance, like you need a very well-trained radiologist. Like if you're a young physio with no skill whatsoever in reading an MRI, how on earth are you supposed to decide on where that tear is? If someone's walking in with an acutely injured ACL and you're talking about cross-bracing protocol, they could be day 28 plus have like massive displacement and you're saying, let's get into a brace. Like that's completely inappropriate.
That's right. And then, we've had a few people with that exactly come to us. Like I had one that comes to mind particularly. And, he'd been in the brace for 4 weeks at this point, and he was a construction worker. So he actually wasn't able to work on site because he was in the brace and then wasn't allowed to go on site. His MRI was of, like he had a significant violent injury, a football injury, and it had, we think that the spectrum, Tom talks about the spectrum of violence of injury, like the higher speed or higher forces, higher violence injuries tend to result in higher, more damage, more displacement, more gap distance, more bruising, all of those things, more meniscal potential. And so he had one of these high violence injuries and unfortunately had a very poor potential to heal in the brace. He was also a young guy, 19-year-old, wanted to be unrestricted, played paid country footy, so wanted to return at a high pivoting demand afterwards. And those sort of people, we don't encourage them to go into the brace unless they're predicted to get an ACL OS of 1 heel. I mean, we don't really know this until we've done the ACL, the RCT, but we're pretty knowledgeable after the 1,000 we're up to. In fact, braced on Friday with Tom, number 1,132.
Wow, amazing.
So basically, so he was really cross, this boy, and he wasn't anticoagulated as well. So a whole number of different problems here. So 1, it was dangerous. 2, he was really annoyed because he hadn't been able to work, so he'd lost 4 weeks of income. He was advised to go down the surgical pathway anyway, so now he has to get the brace off, try to get his legs straight, get his working, prep for surgery, a whole different pathway to doing the cross bracing. And so he'd lost time, money, inconvenience, all sorts of things, and it was unsafe. Do you know, like that's just
the perfect storm.
Of why we as physios, it's beyond our scope to be doing this by ourselves. It's
a really important case study to probably just keep us all in check. It's good to know. You talked earlier about the levels of healing, grade 0 being essentially a normal ACL, grade 1, grade 2, grade 3, with that first 80 participants, and now seeing over 1,000. Have you seen a trend that the grade 1s over time move towards a grade 0, or grade 2s sort of stay where they are? What's the trend with how they develop over time?
The trend tends to be like you don't get a grade 0 heel at 12 weeks. And so the Canoon trial study that Steph looked, Stephanie Philbay looked at the healing, that was MRIs at 2 years. Okay, so that's where they got the 0s and the 2s. Do you know they didn't have any grade 1s in that study?
Yes. Yep.
So our grade 1s tend to go to a 0 at by their 1 year MRI. So they have an MRI baseline at 12 weeks to ascertain the healing, and then they have a 12-month MRI.
12-month. Yeah.
And so many of those ones, I can't tell you the exact percentage, but most of them progress to a 0. But there are a few that re-injure and do things, and then they might regress to a 2.
Yep.
Most of the 2s stay as they are. And again, I can't tell you the percentage that change over, but some, I certainly know some patients do tighten and thicken up over time. Yep. And there are also this other group that we see that certainly this is a little bit less scientific, but I can tell you from my clinical perspective, the people that are very fearful to weight bear during the protocol tend to get less mature heel. So when you look at 12-week MRI, they're grayer, they're a little bit more amorphous, they're not as dark, or not, you don't see the nice structured lines of the collagen fibrils. So those definitely seem to darken over time if they do good rehab. Do you know, but it's like, the body's very clever that it actually needs appropriate forces to heal and strengthen things according to the forces put on it.
Yeah, absolutely. Well, that makes sense too. And it kind of, like just like an ACL graft will mature and regenerate over time, 12, 18 months, 24 months post-op, we know that harvest tissue is now going to be looking pretty strong. We probably don't know when it'll stop regenerating and get to the strongest it'll ever look, but
and that's we don't know that with ACLR, and we don't know that about healing, and probably for a really good reason, because if I had a really good heel and you say to me, Jane, do you think I could just biopsy a little bit of that full ACL of yours and just see what it actually looks like? Because the only ones that we might see are ones that have ruptured, maybe weren't great in the first place anyway, So, yeah.
Yeah. Can you talk a little bit about, so there has been some pushback and some criticism about the cross bracing protocol and some of the, the healing that has been discussed. What's been some of the commentary about that?
Well, I suppose, to the point that I just made, we don't have any biopsy data to actually look at the histology of the ligament heel, like we actually don't have that in ACL grafts, as I believe. Do you know? So that's, and a lot of the pushback has been, it's all just scar tissue, that it doesn't. Well, first of all, I've been told my whole career that the ACL doesn't heal, and for all number of reasons, from the fact that it doesn't have a blood supply, which we know is wrong, because why would you take arthrosis otherwise when you rupture your ACL, right? So we definitely know it has a blood supply. And it's also been said that the synovial fluid washes the clot away and things like that, so there's no possibility for it to join up together. There's a number of things, and then a lot of people have said to us that it's only scar tissue, it's not normal ACL collagen healing. But I suppose in the end it comes down to function as well, because like when you put a graft in, like an ACL graft, I mean, it's not normal ACL tissue. It starts off as a hamstring tendon, a patella tendon, a quads tendon, an allograft, somebody else's tendon, or something else. And so that you could say is maybe less normal than
your
own ligament trying to heal. And I suppose, as I said, it comes down to function. So if you look at Dr. Stephanie Filbay's work with the Canoon trial, where she looked at the people that had healing at 2 and 5 years on MRI, and those people were totally unaware of their healing status, because it wasn't something that they were told at the time. It was a retrospective analysis of the MRIs, as I understand it.
Yeah.
And so, but what they did find is those people that had healed ACLs had better functional outcomes than the non-heals, but also, interestingly, better than the ACL reconstructed groups as well.
Right. Yep.
Now, obviously, the numbers we're talking about were very small. Okay, so that's why we have powered this study, the RCT, to be, you know, we've got 180, 90 in each arm that we're looking for to power the study appropriately to make, you know, some at least good conclusions about some of these comparative factors.
Yep.
So I suppose, yeah, in a nutshell, you know, we don't actually know what the histology is of the heel, but functionally, certainly, we've got a 90% return to sport rate in the first 80.
Yep.
And I think of 600 that have been analysed now, there's a very similar return to sport rate. There's a 90% heel, sorry, not a 90% return to sport rate, sorry, a 90% heel rate. And then in 600, I think there's a 94% heel rate. So now I suppose we're getting a bit more selective of who we offer this to. The re-rupture rate has stayed pretty similar. So the re-rupture rate was 14% in our series of 80, and it's after 600 analysed, I think it's 15% or something, but it's definitely still in the realm, if not less than an ACLR group, which is somewhere between 25 and 35%, depending on your age group and your gender and your return to what sort of level pivoting sport and all of those things.
Yeah. Well, that even return to sport rate is much higher than what we'd probably see in our ACL reconstruction group. Was, you know, seeing numbers as low as, you know, 50%, 55% to competitive levels of sport. So,
and it does depend on the grade of heel to the return to sport. You know, like as far as in our cross bracing group, the grade 1s return to sport at a higher rate than the grade 2s, and it seems that the grade 1s or the grade 2s have a slightly higher re-rupture rate, probably with less force than the grade 1s, which you would, because I mean, you've sort of got to distinguish between the contact, you know, high violence contact and the non-contact re-injuries, because they're probably different, a little bit different in their, you know, the genesis of how it happened.
Well, that's good insight, and a good little teaser there for those that aren't aware. The cross bracing protocol is being put head to head to an ACL reconstruction group in the Embrace trial, which they're currently, Jane and her big team of physiotherapists and multidisciplinary team members, they're putting together a randomized control trial, looking to get, what did you say, about 180 in each arm.
So we need 90 in each arm. So
90 in each arm.
You need to be between 16 and 40. You need to be day 16 is the cutoff, and then obviously, most importantly, they need to be comfortable to be randomized into either cross bracing or surgery, because they don't get a choice. The computer chooses for them, and then they get all their rehab paid for in either arm by good physiotherapists who have done the training for the trial, but also they're you know, experienced knee physiotherapists anyway. And then the surgeons are very good surgeons that are, this is only happening in Australia as a multi-centre trial across all states in Australia. So yeah, if you have any patients who are appropriate, please send them along. Uni Melbourne's running the trial.
And I'll share some information too at the end as well to get people a bit more up to speed on this one. And obviously that's going to take a number of years yet to have that hard and firm data, but
probably 5 or so years before that data. RCTs, I think I sat in a meeting every week for a year before we even started recruiting. So it's been really interesting as a clinician to learn the process of an RCT. And you start to become a little bit less critical of research once you've been involved in and understand how difficult it is and all the barriers, you know, that there are.
Yes, absolutely. Most people would probably be fairly versed in the 12-week cross-bracing protocol, but for some people who may not want to go the whole 12 weeks, are there some modifications that can be done to suit their needs?
So again, Dr. Tom Cross has proposed these modifications, and again, we don't really know how they what the outcomes are as they go head to head with each other, or you know, the RCT is only comparing the 12-week protocol, which was the case series, the one that was used in the case series. But there are numbers that are amassing in each of these different protocols. So I suppose there's an 8-week protocol, and it's really, Tom talks about the time at 90 degrees, which is really the differentiating factor. So the 12-week protocol is where you spend 4 weeks at 90 degrees. And obviously, these are the weeks that people find most challenging because they can't put their foot to the ground just because, your knee's bent at 90 degrees. So I do have an 11-year-old now who's trying to tell me he doesn't need crutches because he can walk around like a gremlin. But I said to him, that's probably because you've got an 11-year-old kneecap and an 11-year-old back, right? But it's probably not really the best thing for your acutely injured knee to be doing. So yes, most people are non-weight bearing with crutches for the whole time at 90 degrees. Okay, so some people use, most people use underarm crutches. Some people use a knee scooter or a frame or a wheelchair. Very few people like the iWalk, but that's another possibility. So there are different possibilities. Then in the 8-week protocol, you spend 3 weeks at 90. Then in the 6-week protocol, you spend 2 weeks at 90. So there are different protocols. And in fact, I've shared with you a practitioner resource pack that I've got as a free resource pack for clinicians, and it is in that pack actually, which is Tom's kindly shared with us from his website data about what the different protocols are and how the ranges progress. So
and have you noted anecdotally? Have you seen any differences between? Do you think the 12 weeks tend to do a bit better than the accelerated 6?
Well, let's say, I suppose at the moment, the people that are being advised to do, like Tom advises the length of protocol, not the physio, not me. And I probably have a lot more scope than most physios out there with this. So, and I still don't propose the protocol length. So for the less injured ACL, so I've got one that's just come through this just while we're talking, who's a grade 2 ACL, but she's a young girl. So she'll go into a 6-week protocol because if she's young and you have the opportunity to heal your ACL in a thick length and you're young, that's got to be better than if you heal it and it's a little bit thin and it's a little bit loose, do you know? So she probably doesn't need the 12-week protocol. Probably 6 would be enough for her, do you know? Whereas if somebody is probably got, if they're higher demand and elite, say, then they might do the full 12-week protocol because they want as thick a volume heal as possible, probably to return back to sport. And I've got a few of those that are Australian level ultimate frisbee players, which are a pretty dangerous ACL sport. I've got actually 3 from the same Australian team, crazy, hey? That have all done this protocol. One of them is doing it, the other 2 have done it. And one of them just competed in the World Championships last week, which was a breath-holding moment for me. But anyway, she got through. But she did get an ACLOS 1 heel, and she was also extremely compliant and diligent with her rehab. And I'm certainly not saying that most people would be able to return at the time that she did, but they also have to compete at a much higher level with much more, possibility of danger with contact forces and things like that when you're competing at that sort of level of sport.
And so for those that do the 12-week protocol, the expectation still is return to sport
at
beyond
12
at 12 months. So, for some people who sort of still think I'm just going to brace myself up for 12 weeks and then be magically ready to go by, say, month 4, month 5, there's still, we're still looking at a lengthy rehab. It takes a long time to regather this strength and range of movement, proprioception, power, all those kind of things. So, but you've missed out on surgery. So that's, like if we're seeing people that are pushing back on it's still 12 months to me, whether or not to do surgery or not, it's like, well, you've missed out on surgery. It's just
that's right. And so that's something that, I certainly is within my scope with my publications that I've been involved with the shared decision-making and my involvement in this is I talk at length with people about the pros and cons of non-operative versus operative versus cross-bracing. And of course, the cross-bracing, yes, you miss out on surgery, which means that you also don't have a graft harvest morbidity, hamstrings or your quads or your patella tendon or whichever they take, that you also don't have the cost of surgery, which is boon for some people, particularly if they don't have private health insurance.
Yeah.
And then there are risks involved in surgery as well. So you don't, have to incur the risks of surgery. But I suppose on the flip side, they do need to be willing to accept that if they don't get the heal that is predicted, it may cost them time, because of course they've spent, up to 3 months in a brace. And then if they want to do surgery, they then have to recover their knee range of motion and their quad strength and their, all of that stuff, so that they're ready then to have surgery.
Yeah.
And then the other thing is they've already spent money on a brace and rehab and things like that for the 12 weeks. And that doesn't shortcut your rehab after you have a reconstruction. You've got to do that all again. And then the other thing is too, I suppose, is that say if you got a grade 2 heel from the brace, and then you've still got another pinch point of decision making where you think, okay, I've got a grade 2 heel. It's not the best quality heel, but it's a continuous heel from, tibia to femur. And, it is a little bit looser, but it's got a good end feel, and you've got a little bit of a pivot glide, but it's not a climb. It's not. So really then you need to probably do an amount of rehab to fix the strength and neuromuscular control, to ascertain, is your knee going to be stable enough for what your demand is? And that might take you another 3 months. So now here we are 6 months down the track before you then can decide. And in that time, say if your knee isn't stable enough and it gives way, it may do more damage to other structures, meniscal bone, chondral cartilage, which may affect the long-term outcome and health of your knee. So you've got to be accepting of all these different scenarios, that you might spend even 6 months. But say for me, if I did that and I was predicted to get a grade 2 heel, or if was predicted to get a 1 and it did a grade 2, as long as I can walk around the block, do my job, go to the gym, walk my dog, I'm happy. Do you know, and if I can ski for 1 or 2 weeks a year, if I had to wear a brace for that, I'd also be happy. Do you know? Whereas if I was my 20-year-old self, I wouldn't be happy about that.
Yeah, agree.
I want to be more unrestricted, more pivoting, more, now it's all about my kids' sport, not my sport. Do you know, it's life changes as you change in your lifetime, right?
That's right. That's right. And that's where, exactly right, you have to treat the person in front of you. And I think that shared decision-making tool, I think that conversation needs to be done. And once again, most early career clinicians, and even most moderately experienced clinicians, probably don't have the time or skill set to walk someone through this process from start to finish. So how can someone has what are the pathways for other clinicians to refer to yourself or to Tom? Is there systems in place to get this done?
Yeah. So there's a few things that I suppose I can, it is challenging right now because of course there's not enough doctors in Australia, let alone elsewhere in the world, that know about this to be able to manage somebody safely and effectively through the protocol with the anticoagulation and all of those sorts of things, as well as do the shared decision making about the MRI factors and the potential heal. So Tom does consult a lot over telehealth all over the world, but he is one man, right? So you have to remember that. There's another doctor in Rajuri in the North Island of New Zealand who is also doing a number of these. Now, there's a couple of sports physicians in Melbourne that have started to become interested. So you might, contact your sports physician and see, are they happy to take on this? And there's some radiologists as well that are starting to get, of course, they're not going to tell you the potential heal, but they can tell you the MRI factors, which then can help if people are interested to, look at that. And I suppose the other thing that I would encourage, just as a logistical and practical thing, is that, say, my receptionists are also part of my team and an important part of my team. So what I've done in my reception, I have on the desktop, I have a pre-bracing folder, and they sent, so because I suppose most people these days are ringing up and they've got an ACL, I see 20 different ACLs a day, but some of them cross-bracing, some of them non-op, some of them post-op. but many of them cross bracing. And so when they ring up to book an appointment, the receptionist says, "Oh, are you have you had surgery, or are you considering cross bracing, or and how many days are you?" So they know all the questions to ask. And then they send them this pack, and it has links to the decision aid. It has the research. It has a thing on ACL surgery. It has all these sorts of different resources. So the patient can read through those before they come in to see me. And then when they come to see me, we get straight into a more meaningful conversation, because I can say, "Did you read through the resources? Do you have any particular questions? What are your thoughts right now? Your day, 22, so I don't really need to talk about the cross bracing protocol, so let's talk about non-op versus op and what your situation is, or your day 4 and you have an appropriate tear for possibly managing it through the cross bracing protocol, or the RCT, in fact, or non-operative or operative, and that's a much longer conversation, and often takes me a whole consult, and sometimes we come to no decision at the end, which is absolutely fine, because what I say to them is, it's still early days, and if you want to preserve your option of possibly still doing the bracing, in the practitioner resource booklet that I've sent along, there's a little slide that I've got ACL first aid, right? And so this is how to preserve your option while you're thinking, because I think you have to be really, like I'll say to people, I'm not going to brace you today because I know you haven't totally made the decision yet about what pathway you want to do, and you've still got time. So go away, breathe a little bit more, talk to your friends and your family and see, and then we'll see. I'll fit you in a day or two. We can do it then. But in the meantime, you have to get on some crutches. You have to non-weight bear. You have to make sure you're still doing your calf pumps, so that you're making sure you're looking after your DVT risk. And I don't want you to straighten out your leg, because obviously that's going to stretch out the injured ACL. And so you can do some little quads clenches, just activation stuff. And then, so look after that, and then we'll see you in a couple of days' time, and then we'll have another discussion about what you're going to do. Awesome. I don't tend to sell them a brace at that time, because if they decide they're not going down the bracing protocol, then they don't need a brace. And if they are going down the bracing protocol route, maybe they don't want a cheap brace. Maybe they want the more expensive brace, particularly if they're doing the 12-week protocol.
I agree. That's a really lovely kind of insight there, because I think a lot of people would probably rush into the decision one way or another, but that kind of acute kind of management that still leaves the door open and allows them to sort of take their own time in making that decision, I think is super important. It kind of really develops a really good therapeutic alliance and some trust, and makes you so less look like a salesperson kind of thing. And I think that's for someone you're meeting for the first time, I think it's going to be a big decision they're going to make. So to give them some time to think about that, super important.
And then sometimes, depending on if they have other injuries, they might go and consult with a surgeon as well in that time, to see what the opinion from the surgeon is as well. So there's a number of different parts in that shared decision-making time point that are important. And I suppose it's just important as physios to work within your scope. Like if you don't have that, then it might be better to, for them to see a doctor who might be more used to having those conversations. But it's certainly something now, I've got a 17-hour cross-bracing course for physios, and there's a whole hour that is dedicated in that to role play that shared decision-making, both on the acute injury side, but also the healing side once they, get their 12-week heal, and how you work with them going forwards as far as, how much, what do they do now? I suppose the nicest, it's always very disappointing when somebody doesn't get the the good quality heel that, but like one example I can share with you is I had a young girl and her mum come along, and her mum, who was a physio, who really didn't want her daughter to have surgery if possible. So they were willing to take a bit of a risk, even though the potential healing prediction was not great, 50% or something. Anyway, they took the risk and did the protocol, and they didn't get, they got what was predicted, which was a grade 2 heel, which wasn't adequate for the girl's demand. They were both upset, but I still think that I probably did a great job, as did Tom Cross in this case, because we both said, they said, we're not upset at you or at Tom. You told us this is how it was in the beginning, and you supported us through this anyway, and it was our choice. We're just disappointed that it didn't turn out better than you told us. So and we're fully accepting that that was our choice, and now we have to do the surgery. You told us this was the risk, and this is what happened. So we're not upset about that, but we're just disappointed. And so I think that's the best case scenario in a bad situation.
Yes, agree.
Rather than people come back and they say, I'm really angry because you said that I would get a good heel and I haven't, and my knee gives way, and now I've ripped my meniscus and I'm really unhappy with you.
Yep. And that's something that we probably, most clinicians, once again, probably won't have that level of insight to identify, risk of healing and, percentage of healing, that kind of stuff. So once again, I think there's some really good pathways you sort of put forward there to get people, talking to the right clinicians, experienced clinicians in this process. So moving on to the bracing, you have talked about the braces, lots of different bracing options, different brands, different styles. Is there any one in particular that's a bit firmer or better than others, or more accurate in its range of movement, restriction, that kind of stuff?
Yeah, well, I suppose, as I said, in the case series, the first 80 just had a normal range of motion brace, which is just like your standard, little dials with put it in different places, Velcro. It's almost more joined by Velcro than anything else. And like, as I say to the patients, there's risks and benefits to all of these things as well. I said that the whole session with me is all about shared decision-making. Now that you've chosen the brace, now we've got chosen the bracing protocol. Now we've got to choose the brace, And this one is, the ROMs are anywhere between, 250 and 350 or something like that, Australian dollars. And then you've got braces like the Bauerfeind Secutech and also the Medi Comfort 4, which are much what I call a hard shell brace. So these are very structured. They have different ways that and they both have manufactured blocks that are suitable for the bracing protocol, the cross bracing protocol ranges. And so, but they are a little bit more tricky. And when I first started to learn to fit either of them, it took me about 45 minutes. Now I can do it in about 20 minutes if everything goes according to plan, but they are a bit fiddly. And again, in the course, I teach people how to do all the braces, from the ROM braces to, the other hard shell braces, because the hard shell braces are about $1,000 Australian. So everyone, especially if you're in a 6-week protocol, you might really think, do I really want to spend $1,000 on a brace? Maybe I'll just spend, and also if it's only a grade 2 tear, and why do I need to, and I'm only in it for 6 weeks, maybe I'll just do a ROM. Plus, I can change it myself. The physio really needs to change the bracing angles. The other two, because it is much more difficult. I have done it over telehealth, but it can be a very difficult thing it's a bit like explaining somebody with an IKEA, box, how to put something together over telehealth. If you can imagine that.
Yes, quite the difficulty. I would not be at all helpful in that. So
it can be much more difficult. Although saying that, the bracing companies There are videos that are helpful. They are also very helpful themselves to assist patients, but they generally also don't send the braces out to, like, people can't buy these braces online for the bracing generally. And they are, like, to explain some of the logistics of why that's so is, like, say the Bowfine and the Medi, they both come in a left and a right brace, right? So you need the correct side of leg, and then they come in about 7 different sizes, right? And you've got to measure in the right place and get the right circumference measurement to get the right brace size and side. So it's very difficult for the average person who doesn't do this, and even for a physio who's not used to it. Like, that's another obviously part of the course, as I said, and takes people like an hour in this session to learn how to do these brace fittings.
Would an orthopedist or orthopedist be someone also to
So the orthotists, certainly they're expert at that sort of thing. So I suppose as like say in the Embrace trial, there in Australia, there is a brace fitting clinic for the Embrace trial in Perth, in Melbourne, in Sydney, and in Brisbane. So of course those, and Bowfinder is the brace company that we're partnering with for the Embrace trial. So certainly people in those brace fitting clinics will be experienced at fitting those braces because they've been taught how to do them.
Yep, very good. One of the concerns of the bracing is a stiff knee and a knee that just won't restore range of movement. What's your experience been with the thousands of people that you've seen involved in this trial?
I know. Well, that is actually, I haven't seen thousands, but I certainly have seen more than 100 for sure. But, so it is one of the criticisms that we have had of the protocol. Like, people have said to us, it's no good. You'll end up looking like a flamingo. Your leg will never go straight again. Do you know? And that's certainly not true. Not true, right? So, and in fact, I think in the case series, there was 14% of people that had some stiffness, and they were all resolved after 3 weeks of. I mean, saying that, there are some people that do get, like, now that we've got more numbers, there certainly are some people that do get stiff, but they don't look like a flamingo for their lifetime. But they are certainly harder sometimes to get full extension for. But I'll share you some of the tips that I think helps.
No, please do.
Right. So, but basically, there's a few things. Again, as the brace angle changes, so you go from 90-90, well, one thing that I think helps at 90 is that you're seeing them weekly, you're doing a bit of soft tissue stuff through the quads and the hamstrings and the calf, and some mobilization through the joints, the superior tib fib joint and patellofemoral, which normally move with walking, which obviously are not with when you're non-weight bearing. So probably a little bit of that at 90 helps. Plus some of the exercises that they're doing, where they're doing bridging, sit to stand, like a little wall slide squat, a wall slide hold or something like that. Again, it's activating the muscles. It's getting some, movement through tiny little movement through the joint. That helps. Okay, but the next thing that really helps is when you then change the brace, say the next angle, if we talk about the 12-week program. So if you go 90-60, what I say to the patients is, okay, so when we change the brace 90-60, by the end of this week, before we do the next brace change, I want you to have achieved the available range of the brace. Do you know, like, so don't, not today, not tomorrow, but every day, just a little bit more. So you need to do the passive, like with the friction-free slider, under your desk or whatever, just do some little knee slides, and each time just to respect the pain, but, just slide it out so that you can achieve, so we don't accumulate losses through the time of the protocol as possible. And I think the soft tissue helps. So then what I do is I'll put them in prone, but I'll prop them at 60 degrees, and then I'll get the brace off, or whatever they can tolerate, 70 degrees or whatever. Because obviously their calf gets a little bit tight, their hamstrings get a little bit tight, the soft tissue does. In as well as the articular surface. So doing some soft tissue stuff in that new range helps. And then doing active exercises in the new range. So then if you're doing wall slide, you do the available range. If you're doing bridge, you do some at 90, some at 60. If you're doing, so basically you're getting, trying to do the passive range of the brace. Then you're trying to do the active, activation and muscle recruitment in that range, as well as walking, and gait is really important. So you're trying to make sure that you use the available range with walking with each increase of range.
Yeah.
Certainly, I think this makes a difference. And I can say that, I'm saying it as a clinician, experienced in managing many of these now, because I can tell you when I see people that I manage remotely on telehealth that don't have any physio and sometimes have been in the brace with no guidance, they are always stiffer because they haven't been walking, they haven't been exercising in the range, they haven't even been moving it enough. Like I'm saying, every hour you have to do 10 of them. Do you know that you're awake? Not just once a day. Like you've got to onto it. Do you know?
Yeah, exactly right. And I think that's often, once again, maybe lost in translation, is that, the bracing protocol, it's, maybe it's just this perception that it's quite a passive protocol where you get put into a brace and then you just get these regular little adjustments, and we're kind of getting weekly range of movement improvements. And meanwhile, people are kind of just sitting on their hands, just waiting for time to pass. And it's not that at all. You've got this almost like a post-operative rehab plan that complements the bracing protocol. So you kind of get the best of both worlds. And that's where I've only managed a couple remotely here in Townsville, and I've had no problems with range of movement. And my experience is, after a few days of them in the new range of movement, they kind of find their new range. By the time they finish that week, we're ready to move on to a new range. They kind of get it by the end. And we haven't had this really residual minus 30 degrees loss of extension, or even a minus 10 loss of extension. They've found their way. So I think that's
some people with a severe MCL injury can have some fibrosis that sort of occurs, like scar tissue around that MCL injury. And I've had a few of those that have had to go and have a cortisone later, and that has really helped them. But that's a small minority of the people that we're talking about. I think the majority, as you say, if you're onto the rehab, and they're actually doing more rehab than my ACL reconstruction rehab group, right? Because like they don't actually have to recover from surgery, right? They haven't got any cuts, they haven't had an anesthetic, they haven't all that sort of stuff. So, when the brace, like all my elites are in the gym from the day after they've got the brace on. They're doing unaffected leg, they're doing upper body core, they're doing the cardio they can, whether it's a salt bike or seated ski erg or grinder or whatever they can do. There's a lot you can do. And then you can do isometric leg press, you can do isometric leg extension. Do you know, so there's a lot to do. I suppose the one thing that I should also say, which I think is also in the practitioner pack, is that we don't add in leg extension until 16, because we don't really know what the healing strength of the ACL is. And even though we now know that, say, from 4 weeks with an ACLR, it's said to be safe to add in open chain. And we definitely know from the ACL strain, research, that open chain is more loaded for the ACL. And I've looked in depth at all the different exercises that stress the ACL and how much they stress the ACL when I thought about the rehab protocols for the RCT. And things like, say, a butt-in squat or a wall slide squat is more loaded for the ACL than a butt-out squat. Do you know? Because it's more loaded for the PFJ, but it's also more loaded for the ACL. Do you know, so the last, the first little bit, 90 to 60 in leg extension, actually causes a posterior glide of the tibia. So it's less stress for the ACL. But as you come up into full extension, it causes the anterior glide of the tibia. So it's more stress for the ACL. So I suppose this probably, as time goes on, causes a little bit of stress remodeling as the healing goes on. But I suppose we do need to think about it with exercise selection. Do you know? So Yeah, that's sort of what I thought a lot about. There was some really good biomechanical literature that I read all about that, you know, like things like, say, leg curl, very low stress for the ACL.
Yes. Yeah.
Press, low stress for the ACL. Up high, more PFJ. But again, as you're coming into full extension, more stress. Do you know? So it's different open chain, closed chain, you know, different stresses.
Yeah, and that's why you've got the nice, you know, complementary rehab protocol too that sort of has been published in the initial paper as well, but also too. So I think that's for clinicians to probably sleep better at night, just make sure.
Yeah, the original protocol is a little different to the RCT protocol, because the RCT protocol had a lot more of that science injected into it when we were knowing that we were going for that level. So it is the original protocol, which I know that some people are still teaching online and stuff, is not the protocol of the RCT.
Okay.
Yeah.
All right. Good to know. Good to know. All right.
But I have to say, obviously, you know, we're very grateful to the original protocol designers, you know, like for all of that intel. But I suppose as we've learnt more and had to make more scientific, you know, we've changed a few little things.
Yeah, that's right. Like all things, we learn from the things that we've done. That's great. When do you think the first professional AFL player will wander down the cross bracing protocol? Do you think that's after the Embrace trial, or is it something on the horizon?
Okay, so I've had a couple of SANFL, so that sort of level. In fact, one that I think he was only 6 months when he played the grand final and kicked the winning goal.
Awesome.
6 months post cross bracing. So I know it's not AFL, but we'll talk about elites in a minute. But I've had my first AFLW player who had a really good heel. She had an ACL reconstruction on the other side, so chose against having a reconstruction on her affected side, and was very excited that there was a different option, because she'd had a lot of trouble with her ACL reconstruction. And I suppose this is the other thing that everyone needs to bear in mind, is that even though it's the accepted treatment, things don't always go right with ACL reconstructions. As we know, those of us who are involved in enough of them, there are pros and cons and good and bad outcomes of ACL reconstructions as well, do you know? So and I suppose the other thing is, like, we've had a number of other elites, as I said, the Australian, you know, ultimate frisbee players, and I've had also a number of musical theatre performers.
Cool.
And dancers who don't want the cosmesis or graft morbidity for their long-term work. And they have returned to work quite early, like one of them who was the lead performer of one of the shows that was in Australia but now has gone to Singapore and Korea now. He returned to work at 5.5 months. Do you know, like, and so obviously he was, what did they say? He was a singer that danced rather than a dancer that Does that make sense? You know how sometimes in musical theatre they do singing and a little bit of skipping and jumping, that type of musical theatre, rather than the ensemble dancer that has to do what everyone else is doing. So I've got one of those at the minute as well. So I think with AFL, it is it's not a really high priority of ours to get these people into the protocol, because I suppose if you think about, you know, if we talk about ACL incidence rates, which are unfortunately, you know, exponentially increasing in the next 5 years, you know, doubling, you know, most in the 5 to 14-year-old age groups. You know, there's a lot of people out there that are, you know, affected by ACL injuries, compared to the small amount of elite, high media profiled, you know, AFL players in Australia and other soccer players around the world. And I suppose for them, you know, the shared decision-making piece is a very different piece for them. There's a lot of stakeholders in their decision. You know, if it didn't go well for them, then time, you know, they might 2 seasons rather than 1. I mean, being that we know what the re-rupture rate of the AFL players is very high. Do you know, like ACL reconstruction? So, you know, their re-injury rate is very high. Do you know? So, I think it will be a brave AFL player or a brave or nearly retired or very young and got a long career ahead of them. So I think it's sort of going to be probably one of those groups of people, either quite young and, you know, want to, because obviously you don't have so much trauma to the knee joint itself if you do surgery, or, you know, older, and then maybe if you didn't do well, maybe you're going to retire anyway, so don't worry about it. You know?
And that's just the nature of the beast, right? So I agree. I think that it will take a brave organisation. It probably take, I reckon it'll be until the Embrace trial has been sort of done and dusted, and people take a probably sleep better at night kind of situation. But until then, it'll probably be largely left to the non-paid professional people.
Yeah, or as I say, the competitive recreationals. Do you know, like there's a lot of them. And I think the other really exciting group is the young open growth plate group. Do you know, like this is another group that I'm seeing more and more of, is that, oh sorry, my phone is clicking. We're seeing more and more of the young open growth plate group, because there's more risks involved in their surgery. And also the surgery is more difficult. So not all surgeons can do fuzzy or sparing or reconstructions. And then the other, like I had another nice clinical example for you the other day, that this man came in who was a physio actually. So, because obviously a lot of medical people learn about as they happen first. And he's very tall, and he brought his 10-year-old boy with him, and he said, I think my son's going to be as tall as me, and if he had surgery and then got growth plate arrest, he would have a big leg discrepancy with a huge lifelong disability, and I don't want that. You know, so I would rather try the brace and see what sort of heal he gets, even if it's to tie him over till his growth plates close a little bit more, and then he has a more adult form of reconstruction with less risk. That's what I would choose. Do you know? So people are like having very informed conversations for different reasons, which is why the shared decision-making piece is so complicated to teach.
Well, Jane, this has been fascinating chat, and it's well and truly opened up my eyes and ears to a really important conversation that we need to be having. So hopefully our listeners today have also too been taking note and listening. And thanks for passing on those resources. We'll make sure that clinicians too can get access to that and help there. Any final closing comments, Jane, before we wrap up? Any words of wisdom or hot tips or pieces of advice for clinicians out there managing the acutely injured ACL patient?
Well, I suppose, let me just think how I can summarize these things. But I think that, well, firstly, make sure you know what you're dealing with, and it is an ACL injury, okay? And it is different if it's an index injury to an instability episode on a previous index injury, number one. Two, try and be familiar or familiarise yourself with the shared decision-making resources that are out there that can help people to be more aware of what options are available, because we know that probably even left up to many physios, surgeons and doctors, much of the advice that they are receiving in Australia, according to our research, is not evidence-based, and it's not unbiased as well. Do you know, like, so I think make sure that you are aware of the resources, the good quality resources that are out there, and direct patients to that point so that they can be a bit more informed in making some decisions that might be better suited for them. And then I suppose there's some, the practitioner resource booklet has some very good tools to help people with that. But then you've got to try and find a team of people around you that can support the patient, no matter what decision they choose, whether it's surgery and you have a good surgeon, or, you know, if they want to do cross bracing, that you refer them to a doctor, or a good quality MRI and a doctor that knows how to do it, and then a physio that also knows how to do it. And if it's non-operative, the same, that they need to have a physio that has the knowledge, but also the equipment. Do you know, because you need some, as
Yep.
you know, Mick, it's very hard to do it with a couple of hand weights and TheraBand. We tried that
Yes.
over COVID, and they
Yep.
don't do as well.
No.
Let's say it's much better to have a gym set up, or to encourage them in a gym setup, but also have some criteria-based testing, because at the end of the cross-bracing protocol, and I think this is what also some people don't understand, is that you're really then just dealing with a bog standard ACL reconstruction, non-operative or cross-bracing rehab protocol based on acute, intermediate, late stage criteria-based management and return to sport testing. Do you know, like, so, and they become quite, you know, generic, whether they are, but you're really thinking about, you know, if they're sort of an ACLR, what sort of graft, and what do you need to recover from the graft site morbidity? If they're a heel, what type of heel have they had, and, you know, what sort of control, you know, do you need to look out for? If they're a non-op, the same, because before they develop enough strength in your muscular control, some of the non-ops also have instability. It's related to the fact that they don't have good strength in neuromuscular control yet. Do you know? So there's just different things for different people. But I think that the world is becoming a better place for people with ACL injuries, in that we are getting more knowledgeable. But the thing is, and I think people need to do some prevention program stuff. Because, you know, we know that works, and just that, but it doesn't work if you don't do it. So, and I think, unfortunately, the risks are increasing. So I just think that we need to be a bit more onto this, do you know?
Well, I had a lovely chat with Matt Wallen a few weeks ago, and we talked about some of the ways we can try and overcome some of these barriers about ACL injury prevention programs being done consistently. And it's going to be the song that we keep on singing. And, you know, if we can keep on just repeating that message over and over again, maybe it'll sink in and sink in the people that we need to be listening.
And and hopefully, you know, between us and other, you know, passionate ACL practitioners, we can at least try to help leave a legacy to make the world a better place for people with ACL injuries, and maybe people that maybe don't even get them because they do the stuff that
Well, you're doing an amazing job, Jane, and I've got amazing respect for you and your team, and keep doing your amazing work. And
thanks. And
thank you.
I'd like to thank the team, because of course, you know, without the team I wouldn't be here. So, you know, Dr. Tom Cross, the Stadium Physio team, Stephanie Philbay, University of Melbourne team, the amazing Embrace, you know, research team as well. So thanks everyone.
You've got such a great community there. Well, Jane, thanks very much once again for your time and expertise. It's been a wonderful chat, and I hope everyone here listening and reading this, I would turn this into a blog so people can read it, but also too, who want to spend the time watching it, have learnt a ton, which no doubt they have. So thank you, Jane, once again. Thanks for coming.
Thanks, Mick. Thanks.
All right, guys. Well, thanks very much once again for tuning in, and stay tuned for the next episode of interviews on the ACL Hub. Until next time, see you.
See you.